Okay, so it's 5 o'clock. We'll go ahead and get started. Really looks like we have about half of the class here, so hopefully others join shortly. I only know of 1 or 2 students that are supposed to be out. So before we start, let's revisit and kind of recap a little bit about what we discussed on Tuesday when we started looking at the history of the U.S. healthcare delivery system. And we talked about 2 particular time periods in the history of medical service delivery. The first was pre-industrial America. And Jenna, do you remember any of the characteristics of the pre-industrial era in American healthcare?
As in, like, the methods that they used? I remember you saying something about them using, like, leeches.
Yeah, so very rudimentary medical practices. What about training?
There wasn't really any training.
Right, there weren't medical schools or any kind of formal education for doctors. Most of the care was done either through apprenticeship or family members would render care to neighbors and homeopathic kind of treatments. What about medical institutions? We said there weren't any medical schools, but what about hospitals? Do you remember, Jenna, if hospitals, who they treated and if it was a place you wanted to visit as a patient?
I don't remember exactly because I think I started mixing the pre-industrial and post-industrial because I know there weren't like asylums or anything until like the post-industrial. Exactly who they treated. I can't remember exactly.
Hospitals were mostly for those that were poor or didn't have family or local neighbors to assist them. So they would be taken there for care, but there weren't great sanitary practices, and there weren't any kind of technological advances like we associate with hospitals today. The hospital was not the place, it was the last place that you wanted to have to go to get care during the pre-industrial period. So post-industrial, we started to see improvements in hospitals. Kaylin, do you remember what helped in the development of hospitals advancing and being a better place to receive care?
Well, they were getting like science education now, so
yeah. What about sanitation practices?
Oh, they were like actually learning how to sanitize things and not spread disease.
And hand washing and those types of things became common practice. You mentioned education reform, so medical training was done based on scientific advances, so less apprenticeship and more formal education was put into place. We talked a little bit about the AMA. Let's see. Lauren V., do you remember what the AMA stands for? Let's see. What about Paige? Paige, do you remember what the AMA stands for?
Yeah, it stands for the American Medical Association.
Yeah, and do you remember what impacts the AMA had during the post-industrial period?
I don't remember exactly, but was it more geared towards like medical education? I think maybe.
Yeah, so they were a proponent of medical providers becoming licensed, so being licensed practitioners, and by doing that, they were able to consolidate kind of their power and impact on the healthcare system by making physician care more coordinated and less individual than it was during the pre-industrial era. And then there were some major medical reforms that started at the turn of the 20th century, but they began in what decade? Taylor, do you remember what decade medical health reform started?
Was it the 1960s?
Yes, my favorite decade. The Kennedy family was the presidential power in the 60s, and they started to look at better ways of treating patients that had mental illness. So evolving past the asylums and kind of the facilities where people were placed and forgotten, more or less, or used in experimental treatments for different types of medical treatments like lobotomies and those types of things. So that is a quick review of pre-industrial, post-industrial era. Then today, we're going to talk about the corporate era and healthcare reform. But to kind of kick off the corporate era, we're going to talk about the history of health insurance. So why would people need to purchase insurance in general? It doesn't even have to be health insurance. Why would you purchase insurance in general? Destiny, do you know?
Just so you can like have the care if you need it, I guess.
Yeah, so for medicine, it's about being able to offset high costs if it's associated with medical care. But any type of insurance is designed to kind of offer you a financial benefit if a large investment, something happens to a large investment where it's going to be really costly to repair or maintain. That's why we have car insurance and homeowners insurance and health insurance. So by having insurance, you're able to be more risk adverse and taking a financial impact should those investments or your health come at risk or be compromised. So in the beginning of the 1960s, so this would be right after Kennedy was assassinated. This would have been during the Johnson administration. They started to look at the rising costs of care, and Congress decided that they were going to seek to pass legislation on offsetting that high cost or the rising cost. So the first broad coverage health insurance in the United States was workers' compensation. So workers' comp insurance was designed to protect you if you became ill and couldn't work, or if you were injured while working. And between 1910 and 1915, so this is way before the 60s and when we started to really look at reform, workers' compensation laws became popular in the United States. So it aligns kind of with people's values. You know, if you were a working person, it made sense that you should have a safety net if something would happen to your health and you weren't able to work. And it was a trial to see how people accepted government-sponsored insurance programs. But despite the implementation of workers' comp, private health insurance programs continued to grow and predominantly be what was available throughout the history of the United States. So in the early 1900s, we started to see private health insurance take root, and it was a lot to do with the fact that people couldn't really predict their need for medical care. They didn't know when something might happen that they would need to access healthcare. So if you remember, 1918 would have been the Spanish flu, so there was a pandemic during that period of time too. So people really started to look at how they could protect themselves if they would need it if they needed to access health care and it became costly. Between 1916 and 1918, there were 16 states, including New York and California, that tried to pass legislation in an effort to compel employers to provide health insurance for their employees. But by and large, those efforts were not successful. So it wasn't until the Great Depression that healthcare insurance really started to be innovative and cover the cost of hospitalization. So hospitals also were vulnerable to their ability to be sustainable from a financial perspective, because if patients couldn't pay their bills, then the hospital wouldn't be able to either. So they too were at risk if they had to offer a great amount of charity care and weren't able to generate the money needed to be operational. So in 1929, Justin Kimball began a health insurance plan for teachers at Baylor University in Dallas. And the model became popular within a few years for Blue Cross plans. And I'm sure most of you have heard of Blue Cross Blue Shield as an insurance company. They are by far one of the more popular insurers here in the state of West Virginia. And at first, there were independent hospitals that kind of copied the Baylor model and what they had done, and they were single hospital plans. So instead of having insurance and you being able to go to any hospital that you wanted, you would have your insurance with a specific hospital. Obviously, the American Hospital Association supported these types of plans, and at the beginning, Blue Cross plans were non-profit. So there were no shareholders or stocks exchanged in the company. It was a nonprofit entity. So by 1946, the plans had grown in popularity, and instead of being isolated to Texas, there were 43 states that offered Blue Cross plans, and they served over 20 million Americans. So just within a few years, there really was a huge impact. So between 1929 and 1946, there was a huge amount of people who began to enroll in health insurance plans for hospital care. So there's Blue Cross, and usually you hear Blue Cross Blue Shield. So Blue Cross was the hospital insurance plan. Blue Shield became the physician plan. So it started with the California Medical Association, and the Blue Shield plan covered physician fees. So if you didn't have to go to the hospital, you weren't admitted in the hospital, you just went to the doctor for general practitioner type care, your Blue Shield policy helped to offset the costs for those types of services. And again, the AMA, there's kind of a pattern in how the AMA over time has impacted healthcare in the United States. So they obviously impacted medical licensure and the practice of medicine becoming a profession, an organized profession, but they also helped proliferate the idea of private health insurance. So in 1974, you had the combination of both the Blue Cross Blue Shield, so plans that covered both hospital and provider professional services. So during World War II was when employment-based health insurance became popular, and employer-sponsored plans were more acceptable. And part of that was because the US Congress had put a freeze on wages. So one of the ways that employers were able to provide benefits to their employees was by offering health insurance. So it's commonly thought of now as an employment benefit, but hasn't always been that way. So when wages were frozen, one of the ways that employers could entice employees to join their company was to offer health insurance benefits to compensate for the loss in wages because wages were frozen. And in 1948, the U.S. Supreme Court ruled that employee benefits were a legitimate part of union management negotiations. So health insurance became an important component of collective bargaining between unions and their employers. Recently, there was a strike. Kellogg's employees went on strike as a result of wages and benefits not being up to par by the union standards. So this is something that's still impacting employee-employer relationships with union-based bargaining today. In 1954, Congress then amended the Internal Revenue Code to make employer-paid health insurance non-taxable. So the employer was able to have a tax benefit by offering employees health insurance coverage. So in subsequent years following the 50s, it's become common for employment-based health insurance to be the #1 means of private insurance for United States citizens. And just to kind of put everything in a nutshell, you have 3 things that really impacted the model of employer-based health insurance: World War II and the freeze on wages, the Supreme Court recognizing employee benefits as a part of collective bargaining with unions, and the third is the non-taxable coverage for employer-paid health insurance. So keep those 3 things in mind. They've been critical and still play a part in employer-based health coverage now. So there's been multiple efforts to put a national health insurance program in place in the United States. One of the first was in 1912, and if you remember from the documentary, Europe kind of adopted national health insurance as quicker and more aligned with a public or a right of individual citizens is to have access to healthcare. So they implemented things much more quickly in Europe and then later in Germany. One of the things that caused an issue with the U.S. adopting national health insurance coverage was the fact that Germany had national health insurance coverage. And as a social principle between the Roosevelt and Woodrow Wilson presidencies, this effort to put social reform in place was a key political issue. But tagging it as social reform or socialized medicine had a negative connotation, and the public as a whole didn't want to accept any kind of model that was synonymous with Germany because of anti-German feelings at the time. So I think it's really important to understand that things didn't happen by chance. There have been cultural value and political forces that have resulted in national health insurance not being adopted in the United States. So this was the first real push for a national insurance type coverage plan. So what are some of the values in American culture that would not support nationalized healthcare? Hunter, can you think of any?
Could you actually restate that? Sorry, my roommate was playing a loud
Sure.
sound in the other room.
What are some of the American cultural values that would make a national insurance plan not appealing to U.S. citizens?
So like the first one that comes to mind is how like Americans typically view like anybody else's problem as not their own. And so like they would also, that kind of connects to how like we refuse to and like look upon like paying more taxes as like a negative thing. So then people don't want to say their tax money is going to go to somebody else, even though they pay more in insurance. But I think I had another one.
What kind of economy do we have?
Capitalist.
Yeah.
Yeah.
The capitalist values and ideas are inconsistent with national insurance plans. Yeah. And then there's one more, you've touched on several. One more that is kind of a driving force is lack of desire to have government interference. So mistrust of the government in managing programs. So we like to leave things more to the private sector than the government. And all of those cultural beliefs and value systems have played a role in the resistance to a national health insurance plan.
I do have a question for you, actually.
Okay.
So the United States post-World War II basically is what designed like Japan's like current capitalist society. But they also have like a national healthcare service. So is it more of a cultural issue as to why we can't have NHS than it is capitalism, or is it more capitalism than cultural?
I don't know that any one element outweighs the next. I mean, I think too, you have to think about terms, and when people that are in political office are campaigning and what their platforms are and how much time they have to get something done.
Yeah.
That's vastly different here than other countries. So there's an overtone of we'll talk about it later in the chapter here today, but part of the reason that the ACA was able to be passed was because you had the same party in political power in Congress and the office of the president. So it's really hard to get any kind of healthcare reform legislation passed under the time limits that a candidate has in office. So
I see. Thank you.
It's kind of like several different things, not just one more than the other, if that.
A compound problem, as public health likes to put it.
Yep, absolutely. Lots of compound problems in public health. And then so we've talked about the cultural values and the political overtones that were in place at the first attempt to put socialized medical reform in place, but also the American Medical Association again played a key role in, and this is going to sound counterintuitive, but opposing national health care. Why would the AMA oppose national health care? Rebecca, do you have any ideas?
Sorry, I couldn't figure out how to get unmuted. So why would the AMA oppose it?
Yeah.
Probably because they'd lose money through it, wouldn't they?
Yeah, usually you can track the dollars, and that's a key influence or factor in why something is happening or not happening. So the AMA opposed national health care because they saw it as a potential threat to practice private medicine. So yes, it would threaten a doctor's ability maybe to earn a specific type of income by practicing medicine, but also, and even today, this is of concern, any type of oversight with medicine, whether it's funding, access, therapies, doctors want to be able to draft their treatment plan for their patient. They don't want interference from external parties in determining what they're able to do or not do in the treatment of their patient. And that aligns very much with our value system, right? You go to the doctor does your exam, and you talk about things that have helped or hindered your treatment, your socioeconomic factors, your genetic factors, all those things that we talked about when we looked at social determinants of health. You go through all of that during your exam, and then your doctor prescribes you a treatment plan. You want them to be able to tell you what is going to work best based on you as an individual patient. So there's always this fear that a nationalized healthcare system will result in the inability for a doctor to independently prescribe a treatment plan for their patient. So in 1946, President Truman was the first president to make a direct appeal for a national health care insurance program. And initially, the public reaction to the plan was positive, but then when government control medical plan was compared with private insurance companies, it started to lose popularity. So the AMA vehemently was against the Truman Plan, and the American Health Association also supported opposal to what was proposed by the administration. And one of the ways that they were able to get public support in the opposition was by comparing what would have been offered if the government plan was put into place versus what was currently offered in the private sector. So in 1948, Truman was reelected while again promising national health insurance. And it was actually kind of a surprise that he continued to press on with that as part of his campaign platform. So because he was relentless, the AMA was able to launch an expensive lobby against what was proposed and campaign directly against the national health insurance and labeled it as communist in ideology, and again rang the alarms about socialized medicine. And by 1950, national health insurance was no longer an issue and remained kind of a dead topic for several decades that followed. So it wasn't until the Clinton administration that again, national health insurance became a top priority. And Americans typically have endorsed tax-supported health insurance, but only for needy citizens or those that have an inability to work and would qualify for social programs like disability. So using the support of the thought of using tax-supported health insurance for needy citizens, there were reforms made during the Clinton administration towards healthcare, but still it was unrealistic for a universal health insurance program to be put into place. So between 1993 and the Clinton administration and 1950, when Truman's proposal died and it was no longer a political campaign topic, in 1965, Medicare and Medicaid became established as government-sponsored healthcare programs. So private insurance was widely available at that time, and the elderly, the unemployed, and the poor had to rely on their own and didn't have access to hospitals or clinics or individual physicians outside of charity care. So most Americans didn't want government intervention in how they received health care, but they were not opposed to reform initiatives for underprivileged classes. So the elderly, those that were 65 years of age and older, started to receive increased attention in the 1950s. And on their own, most of the poor and the elderly were not able to access health care. So in 1957, there was a bill introduced in Congress that started the momentum for hospital and nursing home care as an extension of the Social Security Act. So again, the AMA undertook a massive campaign to portray government-run plans as a threat, and looked at the patient-physician relationship, so that autonomy that I discussed about an individual physician's ability to make a treatment plan designed for or customized for their patient. They attacked that relationship, and the bill stalled as a result of that resistance. So there was a piece of legislation put together that was a compromise. It was the Kerr-Mills Act, and it went into effect in 1960. So enrolling the elderly in welfare programs became a little bit controversial, and liberal congressional representatives voiced opposition that it was a source of humiliation for elderly folks to have to enroll with a government plan. And within 3 years, the program was declared ineffective because many states would not implement it. So on page 65, there's an exhibit that has 6 bulleted items as to why national health insurance has historically failed in the United States. So unlike Europe, national health care failed to get early footing because of labor and political instability in the United States. Decentralization of the American system gave the federal government little to direct control over social policy. The stigma of German socialized medicine has been made synonymous with national health insurance. The AMA has opposed national health care initiatives, and the middle class has traditionally espoused beliefs and values that are consistent with capitalism, self-determination, and distrust of big government. And the middle class has also been adverse to high taxes, as Hunter pointed out, for paying for the cost of a national health care program. So keep all of those factors in mind when considering the history of why national health insurance hasn't been successful. So in 1964, under President Johnson's Great Society program, there was a 3-part program that provided publicly financed health care to all elderly individuals regardless of their income. So the only requirement for qualification was age-based. And initially it was known as Title 18 of the Social Security Act. And funds were used to finance hospital insurance and short-term nursing care services for elderly patients. So Medicare has different parts. There's Part A, Part B, Part C, and Part D. Medicare Part A is designed to use for hospital insurance and short-term nursing home coverage after being discharged from the hospital. Part B is designed to cover physician bills. And then Part C later became managed care, and Part D is prescription drugs. So you'll hear, depending on what's going on during different campaign seasons, references to those different parts of Medicare and how they're funded and how they would be changed by different ideology and political platforms. So again, Part A, hospital, nursing home coverage upon hospital discharge. Part B, provider services. Part C, Medicare Advantage. And then Part D is prescription drugs. So although Title 18 was a Social Security Act, Title 19 of the Social Security Act of 1965 was the start of the Medicaid program. And it was based in significant part on the Kerr-Mills Compromise Act that was put together that was previously unsuccessful. And the idea was that financing would be made available through federal matching funds to the states in accordance with each state's per capita income. So although Medicare and Medicaid were passed as part of the same piece of legislation, the Social Security Act of 1965, Medicare enjoyed a lot of support because there was no class distinction. Medicaid carried a stigma of public welfare. So as a federal program, Medicare had uniform national standards for eligibility and benefits, and the state administered Medicaid programs, and they were varied. So Medicare, federally mandated, more synonymous in how it was implemented. Medicaid, state managed, and more variety in how it was implemented. Medicare covered anyone over the age of 65 or older. So there was a means, whereas with Medicaid, there was a means test, meaning there is an income threshold that if you make below a certain amount annually, you qualify for Medicaid benefits. So many of the poor fell in between the gap of qualifying for Medicaid and the threshold to qualify for Medicaid, but not having enough income to be able to afford private health insurance. Later, Medicare was expanded to cover a couple other categories of people. Non-elderly, disabled people started to receive Social Security for at least 24 months. People with end-stage renal disease and needed dialysis and a kidney transplant also were able to qualify for Medicare benefits. In 1997, that's when Part C was added to Medicare, and in 2003, Part D, the prescription drug benefit, was added to the program. So there are several distinctions between Medicare and Medicaid. I've talked about them, but just to reiterate them because it's hard to remember everything by just hearing it once. So Medicare, to qualify, you have to be how old, Diana?
Oh gosh, I think it's like, is it 25 or 26?
No.
Wait, what was the question? Did you say
How
Medicaid
old-
or Medicare?
Medicare.
Oh, 65.
65 or older
Yeah.
to qualify for Medicare. Medicaid, it's not based on age, it's based on income. So it typically covers, or when it was initially passed, it only covered the poor. The ACA expanded it, but I'm jumping ahead a little bit. For Medicare, there was no income threshold. So again, strictly based on age. No class distinction, whereas there is a class distinction for Medicaid. It's based on those that are needing assistance through public welfare. Medicare has different parts for different service types. Medicaid, all the services are covered under one program. Medicare is federally implemented and is uniformly designed, whereas Medicaid varies from state to state. Title 18 of the Social Security Act was for Medicare. Title 19 was for Medicaid. And Part A of Medicare was financed through payroll tax paid by employees, employers, and self-employed. Part B is subsidized through general taxes, but the participants pay part of the premium. And then Part C and D are done through cost sharing. And basically, cost sharing is when you hear a plan is 80-20 or 60-40, that's a co-insurance amount, meaning the insurance plan covers 60 and then the patient is responsible for 40% of the cost. Cost share also encompasses deductible amounts, which is an amount that you have to pay out of pocket before that co-insurance percentage arrangement is put into place, and it also includes co-payments. So there is some out-of-pocket expense for certain parts of Medicare, whereas with Medicaid, it's financed by the states with matching funds from the federal government according to each state's per capita income. So these are very important differentials that you'll need to remember if you work in the healthcare industry at all. They come up all the time. At the top of page 68, it shows how expenditures between 1965 and 1967 changed in relation to healthcare costs. So there was a significant increase in the total percentage of government expenditures that was going towards healthcare between those two, in that 5-year period. So because of that increase in cost, the latter part of the 20th century and the beginning of the 21st century has marked the beginning of what's referred to as the corporate era. So we had pre-industrial, post-industrial. Now we're going to talk about the corporate era. And the corporate, I have a difficult time saying this word, so bear with me. I don't know why I can't say it, but sometimes I just can't say it. The corporatization of healthcare delivery refers to how the United States has become the domain of large organizations. So we've moved from independent private plans. So at the beginning, when those first Blue Cross private plans came to market, they were with one individual hospital. We've moved from that model to care being managed through MCOs and a whole network of providers and hospitals. Since the 90s, managed care is the primary source for health insurance and the delivery of medical services to a majority of Americans. So we like acronyms in healthcare, and managed care organizations are usually referred to as MCOs. And they're able to utilize their size to obtain purchasing power for healthcare services at discounted prices. So I don't want to go too in the weeds here, but I do want to give you a general understanding about how the system works and what impact MCOs have on health insurance and healthcare costs. So what happens if you're a consumer and you decide that you're going to purchase a policy, you're going to purchase an insurance policy through a managed care organization? That company will have different products. So for the sake of ease of explanation, let's just make them metal plans. So they're going to be gold, silver, and bronze plans. And they say the gold plan is the best plan. It covers 90% of your cost. It has a $1,500 deductible, a nominal copay, we'll say $20 for each time you go to the doctor. But the premium for that gold plan is the most expensive. The bronze plan has a lower premium, so each month you're not paying as much to have health insurance coverage, but it has a higher deductible, meaning instead of $1,500, let's say it's $3,000. So you have to pay $3,000 out of pocket before you get any type of offset through your insurance plan or coverage through your insurance plan. Before they pay on your claims, you have to pay $3,000 out of pocket. And the copays are also higher. Instead of being $20 each time you go to see your primary care doctor, it's $40, and if you see a specialist, it's $75. The silver plan is going to be in between the bronze and the gold. So it's going to have a deductible that's, we'll say, we said gold was $1,500 and bronze is $3,000. So we'll say silver is a $2,000 deductible until your cost share benefits kick in. And copay amount is not as much as the bronze. It's not going to be, I don't remember exactly what it said, but it's not going to be $40. It's going to be $30. And the premium is not as expensive as the gold, but still considerably more expensive than the bronze. So you purchase the silver plan. You decide, I'm going to go in the middle. I don't have to go to the doctor too often, but it's enough of a difference in plan benefits that I don't want to have to pay an astronomical amount in a deductible or a copay. So I'm going to pick the silver plan. So as part of that silver plan, you have a list of benefits, so services that are covered under that plan, and you also have a network of providers that you can go and see. What the MCO does is they collectively build their network of providers by contracting. That's what I do every day, all day. So they contract with providers and they negotiate the cost of the care for their members that have signed up for their gold, silver, and bronze plans. And they say, okay, we're going to allow you to see our members. Our members are going to have access to your services, and you're going to give us a discount off of your charges in exchange for our members to come to you for services. So when you go to the doctor, we'll just say your doctor, the charge for the services to see the doctor it's a $200 visit. You just go for a checkup, the charges are $200. You pay your copay amount, then you give them your silver insurance card. And there is a contractual adjustment that was part of that negotiation that took place between your managed care organization and the hospital or the provider physician's office. So when they get your claim and they process your claim, they apply that discount. So you're not going to pay $200 for your office visit. You automatically get what's called a contractual adjustment off those charges. So let's just say the charges are $200 and your insurance company has negotiated a 20% discount. So instead of your charges being $200 with a 20% discount, that's $40 deducted off of it. So it's $160. So by negotiating what those contractual allowances are and controlling access by their membership of which doctors they can see, they have the ability to impact the cost of care for the members that purchase their gold, silver, and bronze plans. So that's kind of a fairly detailed description of the way that the MCO's role impacts how patients access care, how hospitals negotiate for care. So we talked about the insurance piece. Managed care organizations are the insurance piece. And integrated delivery systems are the provider piece. So very few doctors are currently in private practice, meaning they have their own business that's independent of any larger system or entity. That's not part of a provider group or a hospital group. When I was working in the doctor's office, our practice was a private practice, but you have to remember, I was in dermatology. And dermatology is a very unique medical specialty because we have cosmetic services. Cosmetic services are not based on insurance rates and the system I just described that impacts medical care. They're cash services. So it's no different than any other good or service that you purchase. There aren't any deductions unless we're running a special on that service, and there aren't any discounts unless the manufacturer of your injectable, your dermal filler, your Botox is running a special. And the provider still gets offset from the discount that the pharmaceutical companies take. So because of that cash piece, my dermatology practice where I worked was sheltered from the impact of deep discounts on medical services. We had another revenue stream. So because of that, it was very different. Most primary care physicians, name any specialty, pediatrics, gynecology, ophthalmology, most doctors do not have their own practice any longer. They've become part of larger systems so that they have the same negotiation power and leverage that the insurance companies have been able to obtain under the design of managed care organizations. So as healthcare landscape changes in the corporate era and individual physicians are struggling to maintain their autonomy by having their own private practices, integrated delivery systems have become more the norm. And it's a matter of survival economically that those providers join larger groups or larger health systems. We talked about in the post-industrial era that it was not popular for doctors to be hospital employees. That does not hold true in the corporate era. There's a growing number of physicians that have become employees of hospitals and larger medical corporations. So I'll pause there. I gave you a lot of information. Does anybody have any questions about what I just discussed? Okay. So the next portion of the corporate era has to do with information revolution. And during the course of the last 2 years, we have lived through this key change. And it is the ability to have e-health services or telemedicine services. So pre-pandemic, telemedicine was still pretty obsolete as far as a care delivery mechanism. Post-pandemic, different story. Part of what has equated to that change has been policy that Medicare, CMS has put into place. There were more restrictions before the COVID-19 pandemic on telehealth visits, and those restrictions were significantly decreased during the pandemic. So it's not likely that we'll ever go back to the model that we had before 2020, end of 2019. It's kind of like the genie's already out of the bottle. So patients have become acclimated and physicians have become acclimated to telemedicine services. But that's definitely, pandemic aside, a key factor or element of the corporate era is the revolution of information. We've implemented electronic health record systems and electronic medical record systems to help streamline the exchange of information to improve the quality of care, reduce the duplication of care, and things that inhibited physicians being able to collaborate and work together in the care of a patient. There's also a key factor of the corporate era is global. I cannot say these words, y'all. Globalization. I don't know why I can't say these. But it refers to the various forms of cross-border economic activities. So we're no longer restricted by borders from a standpoint of healthcare services. So telemedicine has played a key role in that. There's also outsourcing of certain medical services like radiology, where physicians in the United States are able to transmit imaging to another doctor that is licensed and credentialed in the United States, but residing overseas. So they can work in tandem to provide care. There's travel abroad, so patients can go to another country to receive a specific type of treatment or state-of-the-art surgeries and state-of-the-art facilities in Europe or India or Thailand for decreased costs in comparison to what the same service would be in the United States. There's also foreign direct investment in health services enterprises. The text mentions American providers such as Johns Hopkins and Cleveland Clinic and Duke have supported innovation and delivery of medical services in collaboration agreements with other countries. And then there are health professionals choosing to move to other countries that offer high demand for their services and support economic opportunities other than their native country. So all of these elements have kind of become earmarks in the corporate era of healthcare in the United States. The last section talks about healthcare reform and goes into depth about the ACA. So the ACA, or the Affordable Care Act, sometimes referred to as Obamacare, was passed in 2010. There was several lawsuits that occurred after the passage of the ACA. And there were two key parts of that piece of legislation that resulted in litigation. The first was the requirement of every American to have health insurance. So there was a penalty if you did not have a financial penalty if you did not have health insurance. The second was the requirement, let me make sure I get this right. The second part was the requirement of expansion of Medicaid programs. So when the ACA was originally passed, the court retained, or the litigation that came after the ACA was passed, the court ruled that the mandates for individual healthcare coverage that every American had to have healthcare was constitutional. And the way that they determined it to be constitutional was by characterizing that requirement as a tax, and Congress had the authority to impose new taxes. The second part, requiring the expansion of Medicaid programs, was determined, the second part of the court's decision is struck down as unconstitutional, the federal government's attempts to coerce states. So the federal government constitutionally has restrictions on what impositions it can make at the state level. There's state sovereignty when it comes to certain elements of regulation. So the Affordable Care Act sought to entice or coerce states to implement that Medicaid expansion. And in a 5-4 decision, the court ruled that these two mandates were not necessarily unconstitutional. In 2014, there was a key Supreme Court case, Burwell versus Hobby Lobby, and it again brought up the constitutionality of the ACA's requirement that employers provide contraceptives that might be deemed to induce abortions. And again, a close decision, 5-4. The court ruled that the case ruled that in the case of a closely held corporation, the owners of which may have deeply held religious convictions against providing drug or devices that may destroy an embryo, the ACO violated the Religious Freedom of Restoration Act of 1993. So the court argued that the ACA's imposition of a substantial burden on religious liberty was unconstitutional. So that ruling permitted that employers did not have to cover all of the services that were originally mandated in the Affordable Care Act. So the text was published in 2018. There's been several things that have happened as far as the ACA reform or an attempt to reverse mandates that were passed in the ACA. The American Health Care Act that was proposed during the Trump administration was not successfully passed. So it looked at reducing funding for Medicaid programs. That was one attempt to change the expansion that was done of Medicaid services through the ACA. But this is an ever-evolving piece of legislation, and it will again be a hot topic in the next presidential election cycle, no doubt. And as we continue to have evolution in our healthcare services and growth and development in our treatments, and the cost continues to impact every element of our economy and lifestyle and value system, healthcare reform will be an ongoing topic, certainly in the next few years. So although the ACA was successful in expanding healthcare insurance coverage to many Americans that prior to 2010 didn't have access, there are still a significant portion of the population that does not have healthcare coverage or is not able to economically afford healthcare coverage. All right, so that's all for eras or spans of change in the U.S. healthcare delivery system. So why do you think, I'll ask for a volunteer here, why do you think that it's important to understand the history and the evolution of the healthcare system in the United States? Why bother talking about these things?
We're ever to make a better situation for health insurance later in life, you kind of know the root how it came to be.
Absolutely. So in order to go ahead, yeah.
I think stuff in history also repeats itself a lot. So learning what it was before, you can understand things in the future.
Absolutely. You guys hit it on the head. So that's exactly why it's important to understand policy, regulation, political climate, and what has impeded or promoted change in the system. It's essential to understand the main characteristics of what exists today, what has predated today, so that we can know what is likely to shape and play a vital role going forward. So while some of this seems laborious and not super interesting in the grand scheme of discussion, it is important to understand and have a working knowledge of federal and state legislation that's impacted the evolution of our healthcare delivery system. Are there any questions? All right. So next class session, so Tuesday, we'll go through chapter 4. And chapter 4 is the different provider types. in healthcare. So we will go through the entirety of Chapter 4 on Tuesday. On Thursday, we will have the first quiz. So the class time will be dedicated to that quiz. It will be posted on Soul. You'll be able to complete it during Thursday's session, so we won't have a live lecture or meet online. You'll just take the quiz, and then you can use any remaining time to read and prepare for the following week's session. So again, Tuesday we'll meet, discuss Chapter 4. Thursday will be the quiz. If time permits, I'd also like to do a few review questions so that you have kind of an idea of what the quiz questions will look like, so it's not a surprise in any way. And then we will go from there. So appreciate your attendance and attentiveness and participation, and I will see you on Tuesday. Have a great weekend.
Thank you.
You're welcome.